Let's talk about lung cancer. This is pretty high yield stuff. It's a bad disease. Want to show you the NCCN guidelines before we start. That's the National Comprehensive Cancer Network. And if you go to their website and you go to treatment by cancer type, we'll go to non-small cell lung cancer, for example, then it'll show you the definitive clinical practice guidelines for treatment of basically, any major cancer type out there. And, the guidelines are extensive. This one is 286 pages, but they're very easily searchable. There's tables of content. Stuff is stratified by the stage of the tumor. There's advice for surveillance and therapy after completion. So if you've never seen this and you're a medical student, highly recommend going and creating an account just that you have this reference available for when you start clinical rotations. It'll help you tremendously. It'll get you oriented and it'll help you figure out what to do next for patients when they come into your clinic. Basically, everybody uses that. Okay, so for step one and step two, and for your in-house exams, there's a few things out of this large lecture that they want to ask you. They want you to know that squamous cell carcinoma is central and adenocarcinoma is peripheral. They want you to understand that if a non-smoker gets a lung cancer, it's probably an adenocarcinoma. They want you to know Pancoast tumors and Horner syndrome. Those are the tumors at the apex of the lung that can impinge certain nerves and even the superior vena cava sometimes. And finally, they want you to know paraneoplastic syndromes. So if you're going to get asked, four questions, those are probably the four things you're going to get asked. Lung cancer is the second most common cancer worldwide and the number one cause of cancer-related mortality worldwide. And peak incidence is in the sixth decade of life. And adenocarcinoma accounts for about half of all cases, and 15% of lung cancers are small cell carcinomas. And this is important because the NCCN guidelines, that website we just looked at, splits up treatment of lung cancer based on whether it's small cell or non-small cell. So that's the first branch point, you might say, in the treatment algorithm after you get a tissue diagnosis. Cigarette smoking's the number one risk factor for lung cancer. Your risk is significantly elevated as opposed to never smokers. And risk is proportionate to volume of smoking and duration, and quitting smoking will lower your risk. There's a small positive correlation between secondhand smoke exposure and lung cancer, but it's definitely nowhere near as strong as if you are a primary smoker. Non-smokers get lung cancer too. About 10% of lung cancers occur in never smokers. And these tend to be adenocarcinomas and tend to present in women, usually in the fourth or fifth decade of life if they're going to get them. There are some other risk factors besides cigarette smoke, different environmental agents. Asbestos is a big environmental factor. And that's the one that you see on TV commercials for mesothelioma. And we're getting asbestos out of buildings these days. I've been in several hospitals that have had entire wings undergoing renovation where they're just pulling the asbestos out of the walls and ceilings because it's a big correlation. And radon is another environmental exposure that's a lot less known about than asbestos. Radon is a chemical element. It's on the periodic table. It's got atomic number 86. It's a noble gas and it's radioactive and it's produced in the decay chains of uranium and radium. And those are compounds or elements that are naturally occurring in the soil and bedrock of most areas geographically. And so when uranium and radium decay, then the atoms that they release, slowly lose protons and neutrons, and so they get smaller and smaller. That's what decay is really. And and they release radon into the atmosphere, and radon becomes a gas, and people breathe it in, and it causes damage, genetic damage to cells in the airway, and that can predispose you to cancer. And so exposure is dependent on where you live and the levels of radium, uranium, et cetera, in the soil and bedrock in your area. And there's testing kits actually that you can procure in order to test the air in your home for radon content. And I'm in North Dakota, and I think it's particularly elevated up here. They're even giving testing kits away for free. But somewhere down south or anywhere else, it may be a little bit lower radon levels in the area. Higher levels tend to be found in basements and underground. So then there's some genetic factors, and also if you have a benign lung disease like COPD, then that predisposes you a little bit to getting lung cancer. Molecular genetics are important to know because these are potential therapeutic targets, and usually targeted chemotherapy is reserved for people with later stage disease, a stage 3 or a stage 4, somebody with metastatic disease that's not resectable, and considering palliative chemotherapy options, that might be the sort of person where you consider targeted therapy for. And the EGFR pathway is one of the most studied when it comes to these biologics. And to my knowledge, there's 7 FDA approved targeted therapies for the EGFR pathway that is often mutated in patients with adenocarcinoma. It's a tyrosine kinase pathway leading to cell proliferation, and in cancer, it gets a oncogenetic gain of function mutation. And ALK and BRAF are also a couple of other good genes to associate with the lungs, particularly. And there are some targeted chemotherapies available for ALK and BRAF as well. That BRAF V600E mutation can be seen in some lung cancers and is also seen in melanomas. Um, and it mentions P53 and RB mutations, but to my knowledge, there's no targeted therapies for P53 or RB mutations. Let's talk about precursor lesions. There's different precursor lesions for different types of lung cancer. It's good to know these for prognostic purposes, but if you encounter a precursor lesion on biopsy, it probably will not change your management that much because you're probably going to refer those patients to get it resected. People generally don't want to leave precancerous stuff growing in their body, and so they want it cut out, even if it's not overtly cancer at the time. So when you get a biopsy and it shows one of these pre-invasive lesions, it informs prognosis for that patient, but mostly the management's going to be resection. So squamous metaplasia is the precursor to squamous cell carcinoma, and you tend to get this in the airways themselves, the bronchi or bronchioles, and you get it because cigarette smoke is an irritant, and the columnar epithelium undergoes a squamous change in response to that chronic irritation in order to tolerate the smoke better. Atypical adenomatous hyperplasia is a precursor lesion to adenocarcinoma. And I would compare this to atypical ductal hyperplasia or atypical lobular hyperplasia in the breast. And if you have a breast lesion or mass that gets biopsied with a core needle biopsy and it shows ADH or ALH, then we generally still recommend surgery to excise the whole lesion because there's a fair chance it can get upstaged to a carcinoma in situ. And upstaging means that your biopsy shows this atypical hyperplasia, but if you go in and cut out the entire affected area and look at it under a microscope, you end up finding carcinoma in situ that was not there in the core needle biopsy result. So the concept is that there's some heterogeneity to tumors, right? They're not all, it's not the exact same cell over and over, even though, conceptually you might think it is. These cells can pick up mutations and you can get different subpopulations of neoplastic cells within one cancer's mass. So, so there might be a more advanced lesion somewhere else in the mass that you miss with your initial biopsy. So that's the concept, and that's why we go in and generally get these atypical hyperplastic areas out. We just remove them surgically. And in the case of atypical adenomatous hyperplasia in the lungs, the data says that about 5 to 10% of the time there will be adenocarcinoma in situ present somewhere in that lesion. And these also tend to be multifocal lesions too. So adenocarcinoma in situ is also it's not totally cancer. It's cells that exhibit neoplastic change, qualitatively, but they have not invaded the basement membrane. So remember that what makes something malignant, when we say malignant, we mean it's neoplastic and it's invading the basement membrane. So we call it in situ if the cells look like malignancy under a microscope, but there's no evidence of basement membrane invasion. Also, adenocarcinoma in situ demonstrates a lipidic growth pattern, and that's a pretty important word to know. It's a good word to know. You'll see it in the NCCN guidelines. You'll see it on pathology reports, and it helps inform, the prognosis. And that word lipidic suggests you're dealing with an adenocarcinoma. Lipidic means it's growing along alveolar septae. Oh, let me get the old marker pulled up. So in this particular image here, along the septae means that kind of grows in a sheet parallel to the walls of the alveolus. Instead of growing like a big old mass out into the lumen and protruding, kind of like an exophytic lesion would, or a papillary lesion, it tends to grow flat and wide, and it tends to cover, again, the surface area of the entire inside of the alveolus. So that's what lipidic means. It grows along the walls, it lines the walls. And then this SDL mentions dipneck, which refers to basically a precancerous lesion for a carcinoid tumor. Okay, let's talk about adenocarcinoma. Most common type of lung cancers, most common type of cancer in non-smokers, but smokers can get it too, tends to be a peripheral lesion. And this is because the cell of origin is the type 2 pneumocyte or the club cell, also called the Clara cell. And both of those are located more distally in the airway. And sometimes adenocarcinomas can arise more centrally. There are different, adenomatous or glandular cells in the airway, so different cell types can become an adenocarcinoma, technically speaking. But the majority tend to be peripheral. And there are a few different types of adenocarcinoma on histology. And one of those types is lipidic. And this is the second time this is mentioned in this lecture. So just understand if you see the word lipidic in a question, they're trying to tell you it's an adenocarcinoma. And these adenocarcinomas stain positive for thyroid transcription factor 1. And that's a really good tumor marker because squamous cell carcinomas do not stain positive for that. Other types of primary lung cancer do not stain for TTF1. So maybe you could have a metastatic colon cancer, I suppose, that would stain positive for that. But those stain differently with regards to cytokeratin staining than the lung cancers do. So if you see TTF1, they're telling you it's an adenocarcinoma. Let's go to our slides and look at some photos. Here's a club cell. Here's a club of club cells. And you can see the secretory granules inside of the cytoplasm. We got cell nucleus right here, but then boop, 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 lots of little granules inside those cells. And this is because club cells are bronchiolar exocrine cells. Remember, there's paracrine and holocrine and endocrine secretion pathways. And this one is exocrine, which means that it makes its products and bundles them in a vesicle and then pops them right out the end of the cell into a lumen. So club cells secrete glycosaminoglycans, which protect the respiratory lining, and they also secrete lysozymes and other things that help to neutralize pathogens, and they secrete the conjugatory protein for immunoglobulin A, which, remember, is the only immunoglobulin which is a dimer. And they used to be called Clara cells, but we, as a field, have moved to deem them club cells instead, so use the word club cell. And then the type 2 pneumocyte is the other, hypothetical cell of origin for these adenocarcinomas. And type 2 pneumocytes secrete surfactant, and they're cuboidal. Surfactant, recall, has phospholipids that have a hydrophilic charged head group, and they've got a hydrophobic lipid tail. And this helps them form interfaces at lots of different places in the body. And remember that the pressure of gas needed to keep an alveolus open is equal to the surface tension multiplied by 2 divided by the radius. And that's the law of Laplace, really similar to wall stress in a ventricle or in any tube. The radius and the pressure multiplied are going to equal your wall tension. So this equation here is why we want surface tension to be low so that alveoli can remain open even at low pressures. And in acute respiratory distress, remember you get fluid in your lungs, and so your surface tension goes way up, which means you need higher pressure to keep the alveoli open, or else they'll collapse, which is why people with ARDS can't really breathe well on room air. And you need positive pressure ventilation with lots of end expiratory pressure, or PEEP, in order to puff their alveoli open. So this equation explains that. So that's the type 2 pneumocyte, just as a review. Here's images of an adenocarcinoma in situ, and on the left, we see a low attenuating ground glass opacity, and a ground glass nodule is just a non-solid nodule. There's solid, non-solid, and part solid nodules. Those are the three main types. And a non-solid nodule is what we call, we refer to it as hazy. It doesn't really have discrete margins. It maybe doesn't enhance as brightly as a solid nodule would. And on the right side of the screen, here we see another good example of a lipidic growth pattern with proliferation along the walls or septae of alveoli. So now here's an invasive adenocarcinoma. This is a good example of a part solid nodule. You can tell that in the middle, it's just a little bit lighter, a little bit denser here, outlined in yellow. And then in green here, you can kind of see that there's a non-solid hazy component around it. So again, that's an example of what a subsolid or part solid nodule looks like. This would be a high risk nodule if you saw it on CT. On the right side, there's an acinar pattern on histology, and that just means the cancer is growing kind of longitudinally along tubes or along the terminal bronchioles. Here is anatomic pathology of a couple of peripheral adenocarcinomas. And I think that these autopsy photos of lung cancers, I remember there being one or two on my exams overall. They like to show you these. I think that in real life, peripheral versus central is a little less big of a deal because if you have suspicion, then it doesn't matter where it is. You need to get a tissue biopsy, which will give you a definitive diagnosis. But they really like to throw peripheral versus central into question stems, and they like to give you the canonical presentations for these different diseases. And so usually they're not trying to fool you, they're not trying to give you the peripheral squamous or the central adenocarcinoma. They're trying to give you the textbook presentation of whatever they're asking you about. And finally, here's TTF1, thyroid transcription factor. It's found in the thyroid. Wow, shocker. But it's also found in the lungs, and it helps you to secrete surfactant. And it's found positive rather, in about 70 to 90% of lung adenocarcinomas. And again, it's not positive in squamous cell carcinoma. So that's a very good tumor stain to know. Here's the paraneoplastic syndrome for lung adenocarcinoma. It's hypertrophic pulmonary osteoarthropathy. And clubbing of the fingers is thought to be related to platelet-derived growth factor and vascular endothelial-derived growth factor. And I'm pretty sure there was a question about this when I took the exam way back in the day. And they said, which of the following circulating substances is responsible for this finding? And I think I put PTGF on that. So I would answer that again. If I got asked that again, I'd say PTGF for the responsible chemical in the bloodstream. Kind of rare. Only about 1% of people with adenocarcinoma get this. Then here's acanthosis nigricans. This is more of a curiosity. I don't think they'll ask you about this. It's darkening of the skin inside naturally occurring creases or folds, such as the neck or the axilla. And that hyperpigmentation can be a sign of an on or underlying cancer. It's related to insulin-like growth factor. And finally, here's Trousseau syndrome, which is associated more so with pancreatic cancer than with primary lung cancer. Trousseau syndrome is migratory thrombophlebitis. So what does that mean? Thrombo, you're getting clots. Phleb, it's in a vein. Itis, it's inflamed. So you have clots in a vein and it's inflamed. Migratory means it's moving, obviously, usually from distally to more proximally. And these tend to affect the superficial veins. So remember that superficial veins are, on top of the muscle fascia, and that deep veins lie underneath the muscle fascia, and you have perforating veins that connect the two. Here's another good example. You can see, there's a linear red streak. It kind of looks like was it lymphospora or whatever? There's like a fungus, that causes swollen lymphatic channels, and it kind of presents like that, except this is in a vein, not in a lymphatic network. Okay, let's go back to the text. Talk about squamous cell carcinoma. It's the second most common type of lung cancer and virtually always occurs in people who smoke cigarettes. And the cell of origin is the basal cell of the bronchial epithelium, which undergoes squamous metaplasia. They tend to be centrally located, and because of this, they can grow into the lumen of a bronchus and obstruct it. And obstruction of a bronchus can lead to characteristic symptoms like wheezing, cough, dyspnea, and post-obstructive infection. And if you get an infection related to obstruction of a bronchus, patient's going to have fever, present with chills, malaise, they feel terrible, they've got an elevated white count, they've got an elevated procalcitonin. So if squamous cell cancers get bad enough, they tend to grow in a big spherical mass so they can get central necrosis and cavitate, unlike the lipidic pattern of adenocarcinomas. And a cavitating lesion is a sphere with a hollow core. And your differential for a cavitating lesion, besides squamous cell lung cancer, is going to include fungal pulmonary pathology and tuberculosis. And histologic subtypes of squamous cell carcinoma are keratinizing, non-keratinizing, and basaloid. They stain positive for P40 or for CK5 or 6, and TTF1 staining is negative. So let's go back to the slides and look at a photo of a cavitating lesion down here. You can tell that the core is hollow, and that's because of, again, central necrosis. Central necrosis occurs because of the Warburg effect, because tumors are not participating in aerobic metabolism, and so they run out of fuel quicker, and they're more prone to becoming necrotic than healthy cells. And you can see cavitating on a plain film or CT even, basically is an air fluid level. Air fluid might make you think lung abscess too, and include that in your differential. And a lung abscess is within the parenchyma of the tissue, whereas if the abscess were in the pleural space between the lung and the chest wall, we'd call that an empyema. So it's the same thing. It's just an infection, and then you get pus because your body's fighting it off. If it's right outside the lung in the pleural space, it's an empyema. If it's inside the lung parenchyma itself, that's a lung abscess. And here's an example of a central squamous cell carcinoma causing obstruction. And It's intruding on the trachea and the main stem bronchus at the level of the carina. And you can use your imagination and see how this airway can get, very partially or almost completely blocked off. And that would trap pathogens distally and lead to a distal post-obstructive pneumonia. And finally, here's an example of pleural invasion. I marked the lung outline in red here and the pleura in yellow. And direct pleural invasion is going to upstage a lung cancer regardless of size. If the visceral pleura is involved, it's a T2, parietal pleura, it's a T3. And if there's a malignant pleural effusion, then that makes it a stage 4 metastatic cancer automatically, regardless of other factors. The paraneoplastic syndrome associated with squamous cell carcinoma is humoral hypercalcemia of malignancy. And this can occur in any lung cancer, but if they give it to you on a question, they're letting you know it's a squamous cell cancer because it's 2 to 3 times as common for squamous cell cancers compared to other subtypes. The rates or the incidence in squamous cell cancers approach 1 in 4, 1 in 5 patients. So you get hypercalcemia as defined as a serum calcium above 10.5, and it can be higher than that. It can be, 12, 13 even. And it's usually due to parathyroid hormone related peptide or PTHRP or PTHRP. And it's got a N-terminus that has great similarity to the N-terminus of parathyroid hormone, so it can bind the same receptor. And PTHRP is made de novo. It's synthesized ectopically by the neoplastic cells and then released into the bloodstream. So it raises blood calcium because it acts exactly the same as how parathyroid hormone was. The way you diagnose it is you check their blood PTH and their parathyroid hormone will be low despite their high calcium. When I think about PTH, the first thing I remember is that calcium and phosphate crystallize together. If you just put them in the same spot, they'll form a crystal. These crystals have jagged edges. They're sharp. They can slice and poke and lacerate the inner walls of blood vessels. And so as a result, your body's got a lot of checks and balances to make sure that calcium and phosphate are never in the same place at the same time. So usually if you're bringing calcium into the bloodstream, you're also pushing phosphate out of the bloodstream in an opposite direction at the same time. So then the next thing I remember about PTH is that it's phosphate trashing hormone, PTH. So it lowers blood phosphate and it raises blood calcium. And then after that, I remember where it acts in the body. It works on bones and it raises calcium by stimulating osteoclast breakdown of bone and pulling that calcium out of mineralized bone. And then it works on the kidneys. And what it tells the kidneys to do is to reabsorb calcium back into the bloodstream and pee out phosphate. And it also tells the kidneys to conjugate vitamin D. That's a very testable point. Vitamin D3 calcitriol is hydroxylated, and then it gets hydroxylated again from 25D3 to 125D3, and then it's really in its active form, and it can go elsewhere in the body. And one of those places it goes is the gut, and it can activated D3, that is, and it can tell the gut it needs to reabsorb, or not reabsorb, it needs to absorb dietary calcium and phosphate. So the effect on the gut of parathyroid hormone is technically indirect. It's mediated by the activation of vitamin D. And then you got to remember that in primary hyperparathyroidism, phosphate will be low unless there's some coexisting renal disease where you can't pee out the phosphate anymore. And then phosphate will start to get elevated. And, that can lead to secondary, tertiary. That's a marker of secondary and tertiary hyperparathyroidism. And finally, if somebody presents, acutely with a calcium of 13, that's a somewhat common electrolyte management question, especially on step 2 or 3. The first thing you're always going to do is give them IV fluids. You're going to hang a liter of fluids, and you're probably just going to hang normal saline because LR's got a little bit of calcium in it. And you're going to give them some fluids and recheck their labs. And, you might give them a diuretic at this point because a diuretic, a loop diuretic especially, makes you pee out calcium. But you never give them the diuretic first until you give them fluids because you don't want to, squeeze fluid out of somebody's system before prehydrating them because that could damage their kidneys if you do that. And then if it's a long-term issue, with a malignancy especially, then a bisphosphonate may be a helpful daily therapy to help keep those calcium levels low and in check. So here's some histology of squamous cell cancers. Here's keratin pearls. They're large. They're neon pink. They're very obvious. You've probably seen these before by now. Here's intercellular bridging. This is less obvious. So I drew a diagram in the lower left of what the bridges are, and they kind of look like just lines going in between cells, bridges connecting these islands of cells, so to speak. And I'll try to kind of label them, you can kind of see them boom, 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 connecting these different cells one to another. So that's a sign that you got a squamous cell cancer going on. Here's a basaloid subtype of a squamous cell carcinoma. And in my mind, it's called basaloid because it's got a bunch of basophilic cells that stain, purple rather than pink. And you notice that it's got kind of slow, gentle rolling margins. It's kind of lumpy. It's kind of bumpy. And finally, remember that squamous cell cancers in the lungs are going to stain positive for P40 and that they're also going to stain positive for CK5 or 6. All right. Let's talk about large cell carcinoma, which is responsible for about 2% of invasive lung cancer. Tends to be peripherally located. It doesn't have distinguishing histologic features. It doesn't really have distinguishing immunostains, and therefore it's a diagnosis of exclusion. You rule everything out, and then you say, well, I guess this is a large cell carcinoma. You tend to see sheets of large, round, pale cells without any obvious differentiating features. And going back to our slides, looking at a large cell carcinoma, here's one grossly. They do tend to grow pretty big. Here are large, pale, clear cells. And what's important to note about these is that the nuclei look relatively normal. And that's going to help you tell it apart from a large cell neuroendocrine tumor that's going to have speckled chromatin in the nucleus with a salt and pepper appearance. So next, the SDL kind of takes a break or a detour and talks about the clinical presentation of lung cancers. This is some good stuff to help you answer questions. Symptoms: cough, dyspnea, hemoptysis, wheezing, pleural effusion. Now, hemoptysis is almost always an indication for further workup in the right patient. Someone who's 17 and, I don't know, have been coughing a bunch with a viral illness and they cough up a little streak of blood, like you don't need to go working them up. But someone who's, 60 and they've got a smoking history and it's their second or third episode, then you should probably get a CT scan at the least on those patients, if not considering, bronchoscopy. A pleural effusion in the setting of lung cancer. I got a few things to say about that. First of all, the laterality tells you a lot in someone with a bilateral effusion, and especially in the right clinical context, you're thinking more so of a transidative cardiogenic effusion. And in someone with a unilateral effusion, especially if they're younger, don't have any heart problems, you're starting to get a little more suspicious. You can get what's called a paraneumotic effusion, paraneumotic meaning around pneumonia, and around meaning temporally. So usually it's you get a pneumonia, and then a couple of weeks later, the pneumonia hasn't fully resolved. You get an inflammatory exudative effusion in the area, reactive to the presence of the pneumonia. And effusions can be malignant, and we will diagnose that with a thoracentesis. You'll have your patient lay lateral decubitus. You put a needle in their pleural space. You aspirate fluid out, and you don't want to take out more than a liter or so at a time because their lung can totally collapse if you take out too much fluid at once with a large effusion. And we use Light's criteria to diagnose these as being transitive or exudative. Transitive meaning there's no or low protein in the solution. Exudative meaning it's a proteinaceous solution. And Light's criteria has three things. There's your pleural to serum albumin ratio over 0.5. There's your pleural to serum LDH ratio, and then there's your pleural LDH, just as a flat number. And if that's over 2/3 the upper limit of normal, that counts. So if your Light's criteria is positive for effusion, then you may send it for cytology. And if cytology comes back with evidence of malignant cells, then that's automatically a stage 4 cancer, M1 metastatic. So other clinical features, you can get hoarseness if a tumor is compressing your recurrent laryngeal nerve. And remember that your recurrent laryngeal nerves take different courses depending on their laterality. On the right side, it goes down and around your right subclavian. On the left side, it goes down and underneath the aortic arch and then recurs around that. And remember that the RLNs are branches of the vagus nerve and that they come from the sixth pharyngeal arch. And because that left one in particular loops around the aorta, then dilation of the atrium of the heart, especially the left atrium, or a thoracic aortic aneurysm can also cause stretch on that nerve, which can present as dyspnea. Superior vena cava syndrome. This one's really interesting because, to my knowledge, it's the only time we ever treat a tumor with emergent radiation. We, call the interventional radiology or the rad onc. We call the radiation oncologist on call and we say, "Come to the hospital right now. You're needed. It's an emergency." Like, nah, no way, no. You're joking. You're pulling my leg. Come on. You're like, no, really, this patient has superior vena cava syndrome. And they're like, oh, I'll be right there. So, it's like the one night out of 365 that your radiation oncologist gets called into the hospital stat at 2 a.m. And this is because, if a tumor is growing next to your SVC and impinging it, then you can get obstructive hemodynamics from that. And what that means is that you can basically, your preload will drop because there's something obstructing blood from flowing into the heart. And other examples of obstructive physiology would be a tension pneumothorax or a cardiac tamponade or a really bad restrictive pericarditis, something like that. And when that happens, then the shock is not going to resolve until you correct the underlying issue. So that's why, hence the radiotherapy, try to shrink that tumor burden. And if it's really bad enough, then there's cases of stenting the superior vena cava open just to hold it open so that blood can get back into the heart and you can increase your cardiac output. So symptoms of this, patient's going to have swelling of their head and neck and possibly their upper extremities as well. And they're going to feel uncomfortable. They may have some dyspnea because of the drop in cardiac output. And especially they'll have JVD or jugular venous distension on examination. And the way you assess this is you lay someone down flat. You don't look for JVD when they're sitting straight up because of gravity. It's going to try to bring the blood down. You lay them flat, you let the blood backflow and pull up into the neck, and you grade your JVD based on how far it goes above the collarbone. You might say, oh, I got a 2 centimeter JVD. If it goes up that far, so I got a 5 centimeter JVD if it's going like all the way up to their, jaw or something. So that's the important clinical finding there. And if they give you superior vena cava syndrome in a question, they'll have swelling and or JVD. Now, Pancoast tumors, these are also really high. These are very highly testable. They want to ask you about these things. You'll see them in UWorld. If you don't see them on your in-house exams, you'll probably see them on your school exams, and you may see it on your actual boards. So a Pancoast tumor is a tumor right at the apex of either lung that pops kind of through the C of the first rib and grows up and out of the rib cage, and it can compress structures in the area. There's your subclavian artery and vein, and a tumor could maybe compress your subclavian vein, predispose you to a clot there. It can compress your brachial plexus, lead to neuropathies of the arm. Can compress your sympathetic chain in the stellate ganglion. Remember, the sympathetic chain starts a little bit lower and then goes back up to reach your face and neck and stuff like that. So that's a Pancoast tumor. That's the location in the apex of the lungs. Pancoast syndrome is when the tumor grows into the nerve roots of the brachial plexus. And just based on location, if it's growing bottom up, it's going to grow into the lower nerve roots first. So you're going to see the ulnar nerve distribution affected before anything else because the ulnar nerve is made up of those lower nerve roots. So you can see paresthesias, weakness, numbness, tingling, atrophy of muscles. That would be pretty rare, honestly. That could be a sign that you need to get a chest plain film. Horner syndrome is when the tumor invades or compresses the sympathetic ganglion. And so, like I mentioned, that sympathetic nerve rebounds back up, kind of like your recurrent laryngeal nerve. And it starts here and then it goes back up to your face. So you'll see a loss of sympathetic function ipsilaterally in the face in Horner syndrome. And the sympathetic function of the face, especially, is going to relate to the dilation of the pupil and its response to light. If you don't have any sympathetic function whatsoever, then you're going to have pinpoint pupils. And it's kind of tough to keep these separated, but just generally remember if somebody's, never mind. I'm not going to talk about that. So you can get eyelid droop as well, and then you can see anhidrosis, or people won't really sweat because sweating is a sympathetically driven process. So maybe if they go to exercise, then only one side is sweating. And you can also see Horner syndrome if you get a stroke. You can see it in lateral medullary syndrome or Wallenberg syndrome when you get a pica, posterior inferior cerebellar artery occlusion. And that would also affect cranial nerves 9, 10, and 11. So you'd see dysphagia, dysarthria with that. And the reason why you get it in that particular stroke is because the sympathetic nerves in your brainstem run laterally, according to the rule of fours. Sympathetic up the side, both of them start with an S. So then the text talks about solitary pulmonary nodules. What you need to know is that a nodule is anything 4 millimeters or bigger. Paraneoplastic syndromes. We've covered most of these. I'll talk about SIADH when we get to small cell cancers. So now neuroendocrine tumors. Small round blue cells, speckled chromatin inside the nuclei, salt and pepper nucleus, cytoplasm containing secretory granules with bioactive peptides. Most neuroendocrine tumors, no matter where they're at in the body, look pretty similar on histology. If you just think small round blue cells, then that accounts for 90% of them histologically. So they're pretty easy to tell apart from non-neuroendocrine lung cancers. There's a couple different types. There's carcinoid tumors, and you can have a typical or an atypical carcinoid. And carcinoids can occur, they're very generic. They can occur basically anywhere neuroendocrine cells are found. They are common in the gut, just I think as a function of square footage. You got a lot of gut. You got a couple of uh, enteric plexuses of nerves. You got a lot of neuroendocrine cells throughout your gut. So the appendix is a common spot. You can get them in the small bowel too. And then from there, they can grow and metastasize to the liver. And when you see them in the gut, you can often see them present with serotonin syndrome or carcinoid syndrome when it's associated with an underlying neoplasm. And that looks like flushing and tachycardia, and especially you'll have problems with your right-sided heart valves, your tricuspid and pulmonary valves. The integrity of those valves can get challenged just due to a high concentration of circulatory serotonin. But your lungs have a lot of neutrophils inside them that absorb the serotonin and kind of just neutralize it and get it out of the system, which is why carcinoid tumors in the lungs typically do not present with carcinoid syndrome as compared to those carcinoids found elsewhere in the body. Carcinoids in the lungs tend to be more centrally located and can be associated with obstructive symptoms, but overall they have a very good survival rate compared to other lung cancers. They present a little bit earlier in life and they can rarely metastasize. But again, overall, the 5 year survival is good or at least fair, compared to other types. Let's look at some photos real quickly of carcinoid tumors. Here's a typical carcinoid showing kind of sheets slash nests of pretty well differentiated cells. The nuclei are not obviously dysplastic. Cells maintain the overall architecture of the tissue is somewhat maintained, but you do see that the cells have speckled nuclear chromatin with a salt and pepper appearance, and it's a little bit more apparent on this zoomed in magnification. But again, you can tell that there's kind of small spots inside these nuclei that are not really present in the non-neuroendocrine tumors. And that's particularly relevant for the large cell neuroendocrine carcinoma because it looks at face value very similar to just a large cell carcinoma. The only big difference being the speckled nuclei. That nuclear change helps you to tell this apart from a large cell carcinoma that's not neuroendocrine if you're given a photo of it. So going back to the text, atypical carcinoids, you're not going to get asked about that. Large cell neuroendocrine carcinoma is an aggressive cancer with a poor prognosis. 5 year survival for stage 1 large cell neuroendocrine is 18%. That's stage 1 disease, not even stage 2, 3, or 4. So this is a pretty bad cancer. They occur peripherally in 65% of cases. And again, you want to look at the nuclei to help tell it apart from something that's not neuroendocrine. And it's going to stain positive for, chromogranin A, neuron-specific enolase, some other, one of those common neuroendocrine stains that you see every block. Small cell lung cancer. Okay. This is important because it's got its own guidelines. Again, the NCCN separates treatment into small cell and non-small cell lung cancer. So that's how important this diagnosis is to patients. It drastically affects their treatment and their prognosis. This is an aggressive cancer. It's associated with smoking. 5 year survival rates are around 15%. It does tend to be centrally located and it tends to be aggressive at presentation, with about 70% of patients having metastatic disease at diagnosis. When you look at small cell lung cancers histologically, neuroendocrine granules are the hallmark, and they will stain positive for neuron-specific enolase, chromogranin, and all that stuff. Presentation has a wide variation, a lot of different ways this can present, no single way. You probably get the gist by now from the rest of the lecture we've had. What they want to ask you about is the paraneoplastic syndromes. So there's three big ones. There's SIADH, there's Cushing syndrome, and then there's the neurologic ones. So SIADH is a good place to start. Antidiuretic hormone is also called vasopressin. They're the same thing. ADH is vasopressin. And ADH is made in the posterior pituitary gland and then secreted into the hypophyseal portal, which is a large capillary network on the underside of the pituitary. And the reason why your body makes vasopressin is to adjust its fluid balance. If you have too much or too little fluid, then your body will change the amount of vasopressin you're making, and that will help maintain homeostasis. And there are two main receptors that vasopressin binds, and the V2 receptor in the kidneys is usually the one that's getting asked about. Now, I just want to say you'll see a bunch of questions related to vasopressin when it comes time to start dedicated boards prep. They love to ask about this. I want to tell you the big thing is to keep the V1 and V2 receptors separate in your head. And for me, the way that I remembered and could tell the two apart is that V1 has a 1 and the number 1 is just a straight line, kind of like how an artery is just a straight line. It's a blood vessel, it's a tube, it's a straight line. So V1, 1 is a straight line, the blood vessel is a straight line, the V1 receptor's on the blood vessel and it vasoconstricts. And then V2 is the other one. So it's on the kidneys because you have two kidneys. There you go. Okay. So that's the V1 and V2 receptors. And again, this whole pathway is extremely relevant. You'll probably see it on step 1, step 2, and step 3, if I had to guess, in some capacity. So ADH works on your kidneys. And what it does in the kidneys is it binds to a stimulatory G protein that uses energy in the form of ATP to upregulate an aquaporin channel. That's AQP. It's a pore for water. And you bring in free water from the distal tubule and from the collecting system. And when you bring in free water, it moves without bringing in salt. And so the water goes into the bloodstream, and because it's free water and not bound to salt, it's going to lower the osmolarity of the bloodstream. So to summarize it, antidiuretic hormone makes you pee less water out. So if you had inappropriate amounts of antidiuretic hormone, you'd have too much of it. So your urine volume would go down. So your urine output is going to drop. And if you're reabsorbing free water, then your sodium in your bloodstream is also going to drop. You're going to get hyponatremic, and that's defined as anything under 136. But, if it's long standing, you'll see 120, 129, 126, 125, and it can be symptomatic or not. And remember that the symptoms of hyponatremia tend to be neurologic, weakness, brain fog, at the worst, seizures. And remember that you don't want to correct sodium quickly. You want to correct it maybe 1 point every couple hours or so, because you don't want to get central pontine myelinolysis or any brain edema or anything like that. So you correct sodium slowly. The only indication for using 3% normal saline is really going to be if there's symptomatic hyponatremia. Otherwise, you can probably just use regular saline and just go low and slow. And in SIADH, again, back to making the diagnosis. So we said that your blood sodium is going to be less than 136. You're going to have dilute blood because you have too much free water. So you're going to have a decreased plasma osmolarity. And that's probably going to be, maybe like 300 to 320 would be normal range. So your plasma osm is probably going to be about 280 or something. And then again, if you're pulling free water out of your urine, then your urine is getting more or less concentrated. It's getting more concentrated. So you would expect there to be an increased urinary osmolarity, and this can range wildly from 50 to 1,000, but it would definitely be greater than 100 or 200 or so. So your urine osm will not be, you will not have dilute urine. You'll have a small volume of concentrated urine. So that's how to make the diagnosis of SIADH. And again, in small cell lung cancer, you get this because the malignant cells make vasopressin and secrete it into the bloodstream. Now let's talk about Cushing's syndrome with Cushing. This is when you overproduce cortisol, generally speaking. So you can get primary. If your adrenals are just overproducing cortisol by themselves, then your ACTH would be low. And ACTH, adrenocorticotropic hormone, made in your brain, released, goes to the adrenals, upregulates production of your mineralocorticoids, your glucocorticoids, and your androgens. So if you have cortisol overproduction, what are the symptoms? Centripetal obesity, big belly, really thin, weak arms and legs, like stick legs, seriously, and very big belly, like a beanbag. And buffalo hump, you can see that. Moon facies, very round face. Skin issues, striae, purple striae, especially on the abdomen. Um, Poor wound healing can be a sign of too much cortisol. And hyperpigmentation can result as well when you have increased ACTH. Um, the most common cause of an increased blood ACTH probably going to be a symptomatic pituitary adenoma that's overproducing it. So if you did suspect hypercortisolism and you got a blood ACTH and it's high, then probably the next thing you should do is get an MRI of the brain to rule out a pituitary adenoma. And if that's negative, then you can go on and get a CT chest, and then you might find a lung cancer that way. But I guess what I'm trying to say is lung cancer is not the most common cause of an elevated adrenocorticotropic hormone. But it is related with small cell. And then finally, the other one related with small cell is going to be Lambert-Eaton syndrome. I remember they asked this question when I took this exam, and they give you the presentation, and they've got limb girdle weakness, and they've got weakness after using their limb, for a minute or whatever, and then they say. Then they tell you they have lung cancer too, or something like that. And then they say, well, what's the mechanism of this paraneoplastic syndrome? So they make it real obvious what they're asking. But then they say something like A, antibodies against voltage-gated calcium channels. B, antibodies against acetylcholinesterase. C, antibodies against postsynaptic acetylcholine receptors. So they're trying to trick you into thinking that it's myasthenia gravis. Because if you have a thymus with a paraneoplastic thymic tumor can cause myasthenia gravis. So maybe they'll give you a mass that's like right there next to it, and you'll have to figure out what's the primary cancer. But I remember getting asked that at some point, and they're trying to see who is awake and paying attention in musculoskeletal block, really. You can see the anti-Yo, the anti-Hu antibodies. They're not going to ask you about that. They probably want to ask you about this Lambert-Eaton syndrome, I think. Okay, so then you can see hamartomas, which can have bone or hair in them, very characteristic appearance, only thing that's going to do that. So if they tell you that there's bone or calcifications, then you can click hamartoma. And you can see calcifications on an X-ray or a CT scan sometimes with those. And then finally, the most common tumors to metastasize to the lungs are going to be primaries from breast, colon, and kidneys. Okay. So last thing I want to do is roll through the NCCN screening guidelines. These are not the exact same thing as the USPSTF guidelines, but they're very similar. I'd say they're 98% similar. And these are recent from October 2024. So who should we screen for lung cancer? We should screen people above the age of 50. The NCCN recommends age 50 to 77. The Preventative Services Task Force says ages 50 to 80. I'd remember 50 to 80 if I was you. So we want to screen people age 50 to 80 with a smoking history. Now, they should have either a smoking pack year history of more than 20 years, or according to USPSTF, anyone who was ever a smoker who quit within the past 15 years should get screened with a low dose screening CT. And that's a strong recommendation. So, who should we not screen for lung cancer? Well, we shouldn't screen anyone who's younger than 50 years old, and screening doesn't provide a benefit in that population. And we shouldn't screen anyone who does not have an extensive smoking history. Screening does not have a benefit in that population. People ineligible for screening are those with a history of a previous lung cancer, because we call it surveillance imaging and not screening at that point. And anyone with a compromised functional status or frailty or comorbidities preventing them from undergoing curative intent treatment, either with lung resection or chemotherapy. So if somebody is 86 years old and they're really healthy, and maybe they do have a 25 pack year smoking history, it'd be reasonable to continue to offer them screening as long as their functional status allows for curative therapy. Here's some good information on what we define as a nodule. I mentioned it before, I'll say it again. A new nodule is defined as anything more than 4 millimeters. So if there's a 2 millimeter spick in there, we're not going to get too, excited about it. That is just a dot, basically. And a nodule is anything up to 3 centimeters in diameter. Anything larger than that, we would just call a mass. And here mentions 3 different types of nodules. There's solid, non-solid, and part solid nodules. And this, mentions specifically a non-solid nodule is also known as a ground glass nodule or a ground glass opacity. And it's got hazy increased attenuation. So that means that it lights up, but it doesn't light up as bright as a solid mass would. And then it doesn't obliterate bronchial or vascular margins. So it's not a bronchial airway process. It's not a vascular process. It must be a parenchymal process. And then a final takeaway from this section is that nodules, when you look at the CT scan, you can put it on different windows to accentuate bone versus lung versus soft tissue. And you should view your lung nodules, your lung nodules on a lung window when you're looking at the CT, because using a soft tissue window can underestimate the size of the nodule. So the 3 different nodules again: solid, part solid, non-solid, and I'm just showing you this to demonstrate that the pathway changes depending on the type of nodule that you encounter. So generally speaking, 8 millimeters is going to be the cutoff for any nodule with a solid component, whether it's totally solid or part solid. If it's more than 8 millimeters, then you're going to want to get further imaging with a higher resolution chest CT or with a PET CT. And that low dose screening CT that we do is low dose because it takes less photos. So the width between the slices is further apart. So it's not the highest resolution possible CT. So most of the time you might want to get a PET, depending on your, degree of suspicion going in. But PET has low sensitivity for small solid nodules and for any nodule type that's near the heart or the diaphragm, because PET works through radio-labeled glucose that gets metabolized, and the heart and diaphragm are highly metabolic structures that can confound the interpretation of that imaging. Another good point is that if you get a biopsy of a suspicious lesion and it's non-diagnostic, you should rebiopsy it. So you could either try the same thing again, or you could use a different approach. a few different things we can do to biopsy. Number one, we can go percutaneously, just straight through the chest wall. Number two, we can do transbronchial biopsies using a bronchoscope and sticking a needle into it. And that's really good for central lesions. And then number three, we could go and do a video-assisted thoracoscopic surgery and just put some ports in and a camera and directly visualize it and take a snip of the tissue that way. So number three, if you really suspect cancer, if the story fits, if the quality of the nodule suggests it, then you don't necessarily need to get a percutaneous biopsy before going to surgery. What you can do instead is you can do one single anesthetic event, and you discuss this with the patient thoroughly beforehand, and you say, hey, what do you want us to do if there's cancer? Do you want us to proceed with the operation? But what you do is you sample the mass and you take it out of the body, and you got a pathologist basically right there in the room, and they do a frozen section and they put it under a microscope right there. And in a short amount of time, they can say, yep, this is malignant, or nope, this is not malignant. And then you can determine what you want to take out and how much you want to take out for a resection based on that immediate pathologic result. So that's an option for people where you're very suspicious for cancer before any biopsies are obtained. And what would make you suspect cancer? What features of a nodule? Good question. So any part solid nodule is a high risk nodule, period. Any non-solid nodule larger than 2 centimeters is high risk, or any non-solid nodule with spiculations is high risk. And then finally, any solid nodule that demonstrates growth over serial CT scans. Those would all be considered high pretest probability for lung cancer rather than not. And then finally, non-solid nodules, if they are malignant or neoplastic, tend to be adenocarcinomas or precursor lesions in the adenocarcinoma line. And if you see a non-solid nodule, then you got to get a very thorough history, because there's a chance that it could be an infectious process, it could be an inflammatory process, it could be a granuloma with inflammation. So oftentimes non-solid nodules just resolve if you follow them on a monthly basis, which is why the size cutoff for those, I think, is a little bit larger, than your pure solid nodules. Yeah, so if you have a non-solid nodule, then, instead of following it on an annual basis, it may be reasonable to get a repeat CT in like 3 to 6 months, a little expedited follow-up to see if that's resolved. So that's what I got about lung cancer. Thanks very much for listening, and good luck on your exams.